Good afternoon, and welcome to this live and recorded webinar session. My name is Dr. Rashonda Chenier. I'm one of the project managers and outreach officers of the Duncan Comprehensive Cancer Center, Office of Outreach and Health Disparities of Baylor College of Medicine. I will serve as today's facilitator during this webinar. Today, we have been fortunate to collaborate with the Colon Cancer Coalition to bring you all this colorectal cancer awareness webinar. Our office typically collaborates with community-based organizations to provide live presentations in our community to educate, inform, empower, and encourage people to take action for colon cancer screenings. The overarching goal is to touch everyone, but primarily men and women who have limited access to care and those that are at high risk. The COVID-19 pandemic has changed the culture of the world and has greatly changed the way in which we provide outreach. It is our hope to provide you all with this informative session and possible ways in which we all can work to raise awareness for cancer prevention during a pandemic. Today, the webinar will go as follows. We will view the colorectal cancer awareness monologue, the bottom line, followed by a brief poll question. We will then have a PowerPoint delivered by Gastroenterologist Milena Gould-Suarez, followed by a live discussion with a Q&A from a diverse panel of experts to contribute to the conversation, to include Dr. Suarez, Aaron Peterson from the Communications Director of the Colon Cancer Coalition, health educators Dr. Rashonda Chenier and Betsy Escobar, and Allison Rosen, who is one of our staff members and happens to be a colon cancer survivor. Feel free to submit questions in the chat feature or the Q&A box throughout the presentation. Lastly, we will have a brief evaluation for everyone to complete through SurveyMonkey. We would greatly appreciate it if you all complete the survey and submit it. This will assist us in learning from these presentations and how we can improve and if our messages are clear to the audience. Aaron, I will now turn this over to you so you can tell the audience a little bit about the Colon Cancer Coalition.
Thank you, Rashonda. Hello, everyone, and welcome. We're so glad to have everyone joining us today. I am Aaron Peterson. I'm the Communications Director for the Colon Cancer Coalition. You may know us best through our Get Your Rear and Gear and Tour de Tush event series. The Colon Cancer Coalition is so happy to partner with Baylor College of Medicine, Duncan Comprehensive Cancer Center, and the Office of Outreach and Health Disparities and the Theater Outreach Program for this webinar today. The focus on colon cancer screening during COVID is a much needed conversation. The coalition's main focus is screening and prevention for our nation's #2 cancer killer, colon and rectal cancer. And as we all know, screening for colorectal cancer and all types of cancer really have been delayed during the COVID-19 pandemic and resulting quarantine. I'm thrilled to be here with Dr. Milena Gould-Suarez, Betsy Escobar, Rashonda Chenier, and Allison Rosen. Thank you, Allison, for putting this all together and inviting the Colon Cancer Coalition to be a part of it. For those of you who don't know, Allison is also the local volunteer event director for Get Your Rear and Gear Houston, and we are so thankful for her hard work and leadership throughout the year. I will be tweeting along from the Colon Cancer Coalition's Twitter account, which is @GYRIG, and also using the hashtag BCMCancer for those of you who would like to tweet along or follow along on Twitter as well. Thank you very much for being here.
Thank you, Aaron. Now I will turn this over for our presentation to view the bottom line.
Hello, everyone. Sorry I'm late. No thanks, baby. I don't want nothing to eat. I just don't feel like eating right now. Oh, this woman's floor. I know this looks funny. Well, I can't help it. I felt like I had to drop a line in the water for Archie. I was passing by our spot, and it feels like the car just pulled itself over. And I've always got my waders at my pole, so there you are. My best friend. My best friend. And he didn't have to go that way. Me and Archie. We were both 9 when he moved onto our street. You know how kids run to watch a moving van? Well, this great big old yellow Mayflower truck pulled up right across the street, and I went flying. Somebody was moving into the old Granberry's house, and I stood there staring with my mouth open, just staring outright, while Mama and I suspect all the other ladies on the street peeked from behind the curtains. Oh, please let them have kids, and please let them be boys. I had 3 sisters, and there really weren't many kids on our street at that time. My sisters was cool, but it sure would have been nice to have a boy my age to hang out with. A pink bike, and another pink bike, and no way! Yes way! A navy blue mongoose with a bright yellow banana seat. And then, oh miracle of miracles, a junior angler fishing rod and reel combo just like mine, in the hand of a boy who looked like he could wear my clothes, with an afro as big as the moon without that flat spot in the back. That was Archie, 9 years old, just like me with the big old grin and not a shy bone in his body. He was my best friend for the rest of his life. His life. His life gone too soon. And for what? Plum stubbornness. That's what. We were inseparable from that first week. It just felt so good to have a boy my age right on my own street. The neighbors called us Pete and Repeat, because when you saw one, you knew the other one wasn't far behind. And did we fish? Fishing helped us get through those tough adolescent years. We had this place we could walk to. It was a clean little freshwater stream full of crappies and brim, and we would just sit there and talk about everything. And after a while, it was pretty much just all about the ladies. He was my brother. We were in high school when we started at Sackers and Big Tex Foods. Before we could start, we had to have a physical. And that physical was the first warning bell for Archie. 15 years old with high cholesterol. I mean, he was okay to work, but the doctor told his mama she needed to do something about the family diet. Well, his daddy didn't want to hear anything about that. Big Archie Smith. Archie was a junior, loved his meat. Barbecues at their house meant platters piled high with every meat you could name. Mr. Smith would tell his wife, "Baby, fix me a plate of those ribs and put a couple of those burgers on the side and give me a couple of those sausage links for dessert. And don't put none of that rabbit food on my plate either. And fix these boys the same thing. Oh, and fix me another little tidy too, will you please?" Big Archie was always known to enjoy a beverage or two, so there was always an array available. No tidy for the boys, of course. Give them a couple of those giant soda waters. Archie ate just like that his whole life. My mama wouldn't stand for it. If I ate at the Smiths, I had to eat a salad or some greens when I got home. There really wasn't much money for college, and Big Tex was one of the few places that paid well and really taught you how to advance. So we went from sackers to cashiers, then managers, then district managers. I'll be retired as a regional manager. I tell you, it was a decent living with good benefits, and best of all, a very deep discount on groceries. And Archie took full advantage of that discount in the meat department. And we got the same discount at the package store connected to Big Tex. So Archie stocked up on spirits. No discount on cigarettes though. But since when did smokers care? I know now that all meat diet was one of the things that put him at risk for that colon cancer. And I'm sure a fairly steady intake of alcohol and cigarettes played a part. You can't tell me different because I read it in my research. Yeah, I researched it. My best friend had it, and I wanted to know everything. What I found out hit me like a bucket of cold water. Colon cancer is the second most common cancer among all people. And we African Americans, men and women, account for the highest number of new cases and the highest number of deaths every year. That doesn't make sense. That doesn't have to happen. Screening could cut out so much of that. Screening is a checkup you get when you don't have any symptoms. It's just something you're supposed to have sense enough to do. Screening can find the polyps that may turn cancerous and the other kind too. It can also catch that cancer in the early stages when it's easy to treat. When we both turned 45, the wives let us know they were in charge of the health situation for the families. You see, they want us black folk to start screening at age 45. Oh yeah, we married best friends, which meant neither of us could get away with anything. I know I couldn't. You see, we actually had health benefits through the job. And when Madam Flora told me I had an appointment right after my 45th birthday, it was, yes, ma'am. And I went on and did it. Happy wife, happy life. Now, the ladies were very good with their screening tests. They would get their mammograms on the same day and then go shopping. And when they became the age for colon screening, it usually starts at 50. They took each other for their colonoscopy exams and stayed in the waiting room for each other. They actually found a precancerous polyp during my wife Flora's colonoscopy and removed it on the spot. Now she just has to go every 5 years instead of every 10. And that's just fine. But see, that thing didn't need to be sitting there waiting to develop into cancer. And what found it? Screening. So my queen is just fine. And you know a king needs his queen. Now Archer's wife, Carmen, had nothing at all. So she goes back in 10 years. Better yet, I tried to get Archie to do the same with me, and that hard-headed brother had a fit. He did take me to my colonoscopy, but gave the nurse his phone number and waited in the parking lot. Rascal. Even being woozy, I was trying to talk him into making a colonoscopy appointment. Now, man, you know I'll go the last mile with you. I did the dentist and the chest x-ray, and I got the pneumonia shot. But I'm drawing the line when it comes to my butt, homie. I know it's gonna hurt. And I remember how miserable that laxative made you all. I ain't doing it. Archie had always been the bravest guy I knew, just not for this very important test. And if anybody needed to get that colonoscopy, it was Archie. Still cramming down the meat. Still quick to raise a glass, always accompanied by a smoke. And the only time I saw him touch an apple was when he'd come into one of my store's produce department and just bite one in front of a horrified produce manager just to mess with me. We all kept after him. And you know how the ladies have a very powerful method of persuading us. Finally, he agreed to at least take the fecal blood test, complaining all the way. Ew, it was nasty. I ain't never doing that again. Now, you know that's the one way they put a little something in a tube one time and the lab checks it out for blood. Well, that one and only test came out negative. And from then on, you couldn't tell him anything. The thing is, if you do that test, you need to do it once a year. But Archie had made it clear to me that the subject was closed. I wish I had tied him up and dragged him. I know Carmen and his kids wished I had too. My best friend. My best friend. I just miss him in so many ways. Archie could reach in your closet and come out with an old shirt and old jacket and have you looking like you just come from the tailor. And nobody could beat him dancing. He would teach me the new steps, and our wives would be the envy of all the wives in the neighborhood, 'cause their husbands danced. And it seemed like he could just make fish. There were days when nobody wasn't catching anything but us. All gone now. You know how you get a feeling sometimes that something is wrong and you can't put your finger on it? A couple of years after the fecal lab, my buddy seemed just a bit not right. His energy was low and his appetite was really down. And of course the answer to what's wrong, Arch, was always nothing. But I knew then it was something. Well, I kept after him until one day he burst out with, "Man, who am I married to, you or Carmen?" He was laughing, but I could see something in his eyes. That's when he told me he had been having bloating with abdominal pain and really bad constipation for about 2 years. I was fit to be tied. He asked me to go along with him to the doctor. Of course I did. The news was bad, really bad. Stage 4 colon cancer. Now that could have been caught and probably cured all right at stage 1. They treated our neighbor, Mr. Joe, stage 1 when he was 70. And he's 86 now and still flirting at the church. And the funny thing, Mr. Joe never was the one to smoke or drink, and he always ate healthy. He got that early diagnosis because he always kept up with his screenings. The doctors tried for remission with chemo, but finally wound up keeping him comfortable for a pretty tough 3 years until the end, which we knew was coming. Knucklehead. A colonoscopy. Just a colonoscopy. Nobody likes them, but they save lives. And we black folk really need to pay attention, because it's killing more of us than anybody. Listen, excuse me, I'm going to just run to the back a minute. Oh, I almost forgot. Archie left us something. Relax, I already got the large ring. But read these pamphlets and take action on that colon exam. Because as much as we miss Archie, let's not plan on joining him anytime soon.
I hope that you all enjoyed the monologue. NAT is a lot like many of us, grieving for someone that was unaware or scared of possibly being sick. However, when we know better, we should do better. While we shift gears a little bit, let's take this quick poll. So, the poll question is, are there several colon cancer screening options? You may click on your screen to reply to the question. Give you guys a couple of seconds. Yes, no, or I don't know. Okay, so, wow. Based off the submitted responses, 97% said yes, there are several colon cancer screening options. 1% said no, there are not several colon cancer screening options. And respectively, 1% said they did not know whether there were several colon cancer screening options. I hope that after the presentation, we'll be able to clear some things up for the 2% that aren't quite sure. So, with that being said, I'm going to introduce you to our featured presenter. Dr. Milena Gould-Suarez is a gastroenterologist at Baylor College of Medicine, Duncan Comprehensive Cancer Center, and primarily cares for patients out of Ben Taub Hospital of the Harris Health System. The Harris Health System is one of Baylor's primary partners in conjunction with UTMD Anderson and is a safety net healthcare system in the Houston-Harris County area. Not only is Dr. Gould-Suarez a gastroenterologist, she also works closely with our office on our advisory board. She's a colorectal cancer advocate and a mentor. She also does not hesitate to provide her voice in the community by attending events and being candid about colorectal cancer awareness. I now introduce to you all Dr. Milena Gould-Suarez.
Thank you, Rashonda, for that great introduction. And I will now share my screen so you can see our slideshow. So the title of today's talk is Fact or Fiction Colon Cancer Screening. And I thought we'd start with this. So I'm going to list a few things, and I want you to think if this is actually a fact or fiction. So colon cancer screening dropped by 86% in March of this year. Screening is only needed if you have symptoms, estimates of missed or delayed diagnosis for colon cancer. It was 18,800 from the time period of March to June. And only people with a family history of colon cancer need to be, can get it. So the fact is that colon cancer screening has dropped by 86% in March. Fiction is that screening is only needed if you have symptoms, where in fact screening is needed for everyone regardless of whether or not you have symptoms. Estimates of missed or delayed diagnosis for colon cancer is 18,800 from March to June. That is also a fact. And only people with a family history of colon cancer can get it, and that is not true. So people without family history of colon cancer are just as also at risk. So speaking of what is going on during this pandemic, we've seen a great decrease, as we mentioned with the numbers, in actually all cancer screening. So if you look at these lines, these are, this is breast cancer, then we're looking at colon cancer and cervical cancer, and they have 4 years of data, and this is the mean weekly screening volume. So usually it's about 3,000 cases per week that we screen, and this dropped to 402, so drastic decrease. So what should you be thinking about screening during the pandemic? Well, I urge you to discuss with your healthcare providers options for screening. As of last Friday, I was doing screening colons, and as of this week, we are only doing inpatients due to the change in the pandemic in Houston. There are changing restrictions that may affect your options for screening. Individual risk factors may influence timing and type of screening. And providers and facilities are taking every precaution to protect their patients. And we can talk about this more later in the discussion, but I know that most places are pre-screening every patient for COVID within 48 hours. And if their test is positive, they are canceling those patients. And we're also wearing a lot of protective gear to protect our patients and the staff. So as was mentioned, colon cancer is the third most common cancer among men and women in the US. It's the second leading cause of death from cancer, and it can largely be prevented with colon cancer screening. So the estimates for this year, and this was done before we had a pandemic, so it might go down a little bit, is about 148,000 new cases and 53,200 deaths. What's important is that the 5-year survival rate varies by stage. So if you have localized, you have a 90% 5-year survival rate. Unfortunately, only about 40% are diagnosed at an early stage. Whereas if you're like Archie and you have stage 4 colon cancer, your survival rate is about 14 to 15% at 5 years. The lifetime risk is pretty similar for men and women. It's about 1 in 23 for men and 1 in 25 for women. And this just shows the progression. So it starts with a polyp that goes in situ, then local, which is associated with a 90% survival rate, then regional and distant, which is stage 4, what Archie had. So epidemiology, who gets sick and why? So about 30 to 50% of our population will develop adenomas or adenomatous polyps over their lifetime, and less than 10% of polyps become malignant. The median age of diagnosis is 66 in men and 69 in women, but there are increasing rates among young adults. And you can see here this drastic increase over time. And in 1990, there was 6% of colon cancer was diagnosed under the age of 50. And in 2013, that went to 11%. Deaths from colon cancer among younger people have increased 2% per year from 2007 to 2016. It's thought that there might be a connection to the body's microbiome, the bacteria that build up in our gut and are influenced by a wide variety of things in our diet and environment. So this slide shows the etiology or cause. So most colon cancers are sporadic. There's few that have a familial history, and then there's these syndromes. And what I think is important in this slide is that the significant majority of cases, 65 to 85%, are diagnosed in individuals who have no identified risk factor other than being over the age of 50. So as we said, age increases your risk, and the risk increases with age. There's a slight male predominance. African Americans have the highest incidence and mortality rates of all groups in the United States. And there's increased rates also in Alaska Native, some American Indian tribes, and Ashkenazi Jews. So you can see slight increase in men over women, obviously over time, age 50 plus, but now this is starting to increase. And then African Americans have the highest rate at this point. Other risk factors include inflammatory bowel disease, namely Crohn's disease and ulcerative colitis, history of adenomatous polyps or colon cancer, and that's a personal history. Family history of adenomatous polyps, colon cancer are one of those syndromes that have polyposis. Type 2 diabetes, acromegaly, streptococcus bovis bacteremia. There are dietary factors that increase risk. So like Archie, eating processed meats and high-fat diets increased his risk. But there are things that you can do to decrease your risk. So vegetables, fruits, and whole grains all are thought to decrease your risk. And World Health Organization has made processed meats a class 1 carcinogen, it is now known that this is a cause of cancer. So limiting that would decrease your risk. Other factors, so physical activity may reduce risk, and excessive alcohol use and smoking increase risk. Obesity also is known to increase risk. So here's just a pictorial of what I just said. So what can you do? You can eat a healthy diet with fruits, vegetables, and whole grains, keep your body mass index in the healthy range, increase your activity level, and avoid smoking. You want to limit processed foods and also a sedentary lifestyle, and have alcohol in moderation. So we're going to talk a little bit about screening. The screening age had been 50 for a long time. American Cancer Society has endorsed screening at age 45. The gastrointestinal societies are still screening most patients at age 50, with the exception of African Americans at age 45. So in 2010, only 59% of people over the age of 50 reported having any form of colon cancer screening. And by 2016, we were up to 67%. This is a map, obviously, of the United States, and the darker the green is the lower your screening rate in your state. So Texas, where we are, 58 to 64%. But you can see the Northeast here is in the 73 to 76%, as well as California and northern states are a little bit higher. So there's, as we alluded to with our question today, there's multiple options for colon cancer screening. So the tier 1 recommendation is to get a colonoscopy every 10 years or to have the annual fecal immunochemical test. We'll talk about both of these today. Other options in tier 2 are CT colonography every 5 years, FIT fecal DNA every 3 years, also known as Cologuard, which we'll also discuss today, and then having a flexible sigmoidoscopy every 10 years or every 5 years. Tier 3 is capsule colonoscopy every 5 years, and the other available test, which is a blood test, is Septin9, and that is not currently recommended. So colonoscopy, fortunately, there are no randomized controlled trials of colonoscopy for screening, but it has many advantages. It has an efficacy in decreasing colon cancer rates and colon cancer deaths. And this is just a picture of what it looks like and the different things that we can diagnose. So it goes in through the rectum and all the way around to your cecum. And here's the appendiceal orifice, and this is the small bowel. The disadvantages are that it requires a full prep. There's a risk of complications, a small risk of perforation, risk of bleeding, and a small risk of death. And it's operator dependent. So it depends on your proceduralist how good they will do in terms of taking a look. And this is what it looks like in real life. This is a polyp on a stalk. We put a snare around it and we can burn it off. And then sometimes we'll tattoo the area if we feel like we might want to go back and take a look. So next is the fecal immunochemical test, also known as the FIT test. Advantages is it's non-invasive. It has a one-time sensitivity for cancer of 79%, and it has a fair sensitivity for advanced adenomas. Those are the bigger polyps that are more likely to become cancer. It's cheap, $20. It can be done at home and it can be mailed in, which is particular advantage in this time of the pandemic. The disadvantages is it requires annual testing, so you have to do this every year. And there's another polyp called a serrated polyp, which does not have sensitivity for it. And those polyps also can turn into colon cancer. So next up is the FIT fecal DNA test. This is also known as the Cologuard test. This uses FIT and markers of abnormal DNA to look for in the stool. It is also FDA approved. So it has the highest single-time testing sensitivity for cancer of any non-invasive, non-imaging colon cancer test. It detects about 92% of cancers and 42% of large colon cancer polyps. The colorectal polyps. It has 40% sensitivity for sessile serrated polyps, the ones that are greater than 1 centimeter. And as I said, FIT does not have a sensitivity for these. Again, it can be done at home and it can be mailed in, which is particularly useful during this time. Disadvantages, there's substantial decrease in specificity, 86% compared with 96% for the FIT test alone. And it's relatively expensive. It's $500 to $600 per test. And you do a higher number of colonoscopies because there are false positives. But you do need it only every 3 years as opposed to the FIT, which is every year. So if there are tests that can prevent colon cancer are preferred, like the colonoscopy, why not recommend them alone? Well, our goal is that we really want to have everybody get some form of colon cancer screening. And so a colonoscopy requires greater patient requirements for successful completion. You have to have a full bowel prep and you require an office and facility visit. And then there's patient preference. Many individuals don't want an invasive test or a test that requires a bowel prep. And some may not have access to the invasive test due to lack of coverage or local resources. For example, in our hospital system, we do not provide regular colon cancer screening through colonoscopy, but our patients get FIT testing, annual FIT testing first, and if that's positive, then we provide colonoscopies. So I'm going to leave you with some take-home facts. Colon cancer and other cancers don't stop for COVID. So it's important to continue doing your screening. Screening is done. It's checking for cancer in patients who have no symptoms. So I want to remind you that obviously if you have symptoms, you need to get checked out. But if you're of age, 50 and above or 45 and above, then you should talk to your provider about getting colon cancer screening. Screening can reduce colorectal cancer mortality by detecting cancer at an early stage, a curable stage, and detecting and removing adenomas, so it can prevent colon cancer from forming. About 75% of patients who get diagnosed with colon cancer have no known risk factor aside from being over the age of 50. And all screening tests aside from the colonoscopy require a colonoscopy if positive. So our goal is to have 80% in every community getting screened for colon cancer. So I know we have a captive audience here, but if you can reach out to your friends and family and get screened, this is what we look like right now. And if you have questions, feel free to reach out to us. There's a QR code here to scan for the survey. And I thank you for your attention, and I look forward to your questions.
Thank you, Dr. Gould, for that amazing presentation. Now I'd like to introduce the panel for this interactive discussion. I am joining this discussion with Dr. Gould-Suarez, my colleague and community health educator, Dr. Betsy Escobar, who will serve as the moderator, and she will also be managing the questions from the Q&A and chat. I would like to introduce Communications Director from the Colon Cancer Coalition again, Erin Peterson, and my other colleague and colorectal cancer survivor, Allison Rosen. Thank you all for being a part of the panel. Betsy, I will now turn things over to you.
Thank you for sharing, Dr. Gould, for your presentation. Some of the questions that you have put in the QA and the chat box have been already answered, and they're very good questions. I'll try my best to answer the ones that we have not covered. So we have a question from Sanford. What is the recommended age to begin screening for African Americans or others with a strong family history of colon cancer? I ask this question because both my parents were diagnosed with colon cancer, my mom at age 40.
So we recommend African Americans get screened at age 45 if there's no family history. If there's a family history, we recommend 10 years younger than the youngest person in your family. And if there's an extensive family history, then sometimes that means that there's a syndrome, and so you may need testing even at an earlier age.
Okay. All right. And some people have been asking whether the age, what is the official age? Is it 50 or is it 45? Some people want some clarification.
So
Can
that is
anybody tell us?
Oh, well, I mean, that's a great question. American Cancer Society just lowered the screening age to 45. And I know that the more research, and I responded in the Q&A box, more research is being done to try to figure out why younger people are getting it. And if there is enough research that shows the increase to be worth screening for younger people, then they will. I mean, I was diagnosed at 30. I was diagnosed at 31, trying to remember when I was diagnosed. But I think, as was stressed by Dr. Gould-Suarez in our presentation, if you have a family history, if you have Crohn's or colitis, if you have blood in your stool, if you have certain things that are going on within your system and your body, the best thing you could do is know your body, talk to your doctor. And if one doctor doesn't listen to you and say, oh, it's just this, oh, it might be hemorrhoids, try to find a doctor that will listen and at least give you a fit test, some sort of test to see if there's microscopic blood in your stool, if you're not seeing blood already. So I'll let either Erin or Milena answer further. But yes, the official age is now been lowered to 45, and I know they're doing a lot of research to try to figure out why. I mean, in my world of advocacy, it would be great if everyone got a screening, but I know financially that's not possible. So they're doing tests to figure out why. The possible screening, blood tests to screen, all different types of things that would make it financially possible, possibly to have a screening as a part of a physical in the future. But that's far away, I think.
I would like to chime in as far as saying research can be out there, but a lot of times the research doesn't match with the industry. So even, and we've had these discussions in our office as well, the guidelines that have come from different agencies may state 45 for screening. However, insurance companies may not have. So you also have to check with your insurance providers to see if they will recommend it. And just like Allison said, one thing that you can be is an advocate for yourself. Whenever you are going into the doctor's office, if you notice that there's things going on with your body that, and you notice any changes, make your doctor be informed, and you're your best voice.
Couldn't have said it better, Rashonda.
Okay, next question. Trisha is asking, do you recommend everyone to be vegan?
Might be a good question for you, Milena.
I do not. I think that everything in moderation. I would definitely avoid fatty processed foods. I think it's fine if you want to be vegan. You just need to make sure that you get all the nutrients and vitamins that you need. And it has been shown to decrease your risk. But I don't think that it's necessary if it's a big step. So I think just making healthy choices is the important take-home point.
Yeah, I know I had to not change my diet considerably, but living in Texas, there's a lot of steak and red meat and burgers. And so I really, like Milena said, I have limited as far as what I eat, as far as processed food, as far as red meat. You know, every once in a while on a special occasion, I will enjoy a steak. I think like Eddie V, I'm not going to eat steak all the time or hot dogs or whatnot. I definitely have changed a lot of my diet to be more plant-based, to include more greens, more color. But that's just overall nutrition for, you know, for a healthy lifestyle. But specifically for colorectal cancer, I think, you know, adapting what you're eating, looking at what you're eating and changing that is a good thing for overall health.
And I think Dr. Gould chimed it, she used it perfectly. Things are in moderation. You can have a person that is vegan that can actually have a poor diet. So it's about having a balance. It's about working out, knowing, you just incorporating different types of vegetables. I like to call it roughage because our intestines are our plumbing, and we need to clear out all the necessary waste so that it can be clear. So just do things in moderation. Drink a lot of water. Try to avoid the processed foods. That'll help out quite a bit in so many different ways. And when we have sedentary lifestyles, and unfortunately, you know, when it kind of put us at a higher risk whenever we're overweight, and that's not only including cancer, but other chronic illnesses.
All right, let's move on to the next question. Sanford is asking, with much of discussion around diet and lifestyle, I am curious to know the effort by cancer centers to collaborate with community-based groups to improve education. What is the current level of collaboration with community-based or faith-based groups? Anybody from outreach can give us some answers?
Well, I think I'll take that question. So I work in the Office of Outreach and Health Disparities, and one of the unique things about being in Houston is that our cancer world is very small, and so we kind of work in conjunction with a lot of different entities. On a local level, we have a lot of colorectal groups, and a couple of them are actually on the Zoom today. And we work with MD Anderson as well. But in conjunction with that, we also being that we are a part of the Bible Belt, there's a lot of faith-based organizations that are around that we will work with and go out into those communities to bring them what we can and find out some of the things that they need. And this is a unique opportunity. We've been in this particular element in which people can't go to church. We actually have been reaching out to do these type of platforms, these virtual platforms, to educate individuals, even working with our safety net institution here in Houston, the Harris Health System, and some of the FQHCs in the area to provide resources for access to care. So, and I know on a national level, this is going across the country. So we're in that regard, we're not unique, but we are doing our part to try to put the community in with the health system so that those that are underserved or do not know exactly where to go, we try to go to the people.
I think the theater outreach program that you help lead, Rashonda, is a perfect example of what we're doing, bringing it to the community, not having them come to us. I think, for example, we're trying to do COVID times, making this virtual. So this same webinar, we're going to have focus groups, and we're going to try to figure out a way that however the church is communicating or faith-based organizations are communicating with their congregants, how we can also have this webinar with them so they have the opportunity to ask questions. Usually we'd be out in the community at health fairs, sometimes delivering this just in smaller groups, 20, 30, sometimes 100. But since we can't do it, we've pivoted to doing virtual. But as soon as we're able to get back out there, we will be back out there. We are grassroots out there where they need us.
And the fact of the matter is that cancer is a heavy topic. Cancer is a topic that no one wants to talk about, whatever ethnicity or culture background you have. And so if we lived in the bubble of working just in the medical setting, we wouldn't be able to actually reach those that would not normally be reached, or those individuals who may not even know how to navigate through a large safety net healthcare system, or even not even knowing how to get eligibility for it. So that is part of our job, and I'm very proud to say that we're a part of it. And I've met some very unique individuals along the way that they don't get the glory. They are the health ministers at churches. They are the individuals that work at the nonprofits that we deal with, that maybe they're providing a service in one entity, maybe educating or helping someone to get somewhere, but we piggyback on those activities in order to spread the word about cancer prevention and how these certain groups may be at higher risk and how they can be able to get care at free or reduced costs.
Erin, I know that there are other programs that you guys have helped fund through grants. Are there any ones in particular you want to talk about? Or examples?
We do a lot of funding for programs that are specifically outreach to minority populations or those that are experiencing health disparities. Several in North Carolina, a couple in the Pacific Northwest. I think what they all have in common, though, is what your team is emulating, being out and being available to the community, and all are pivoting to this virtual environment. So the practices that you guys have implemented are really what we're seeing across the country. So congratulations on that.
Okay. Thank you so much. We have another question. This is for Dr. Gould. Can you explain the sensitivity for colon cancer with the FIT test? And the second part of this question is, what is the most seen stage at initial diagnosis?
So the one-time sensitivity is the true positive. So for FIT testing, it's 79% that if the colon cancer is there, that we will get a positive test, which is why it's an annual test. So if you don't catch it the first time, then the thought is that you would catch it the next year. So that's the importance of the FIT test, is the compliance with doing it every year. But it's a pretty good test. But remember, again, it's a test really to look for cancer as opposed to the colonoscopy, which looks at cancer and polyps. And then you wanted the statistics on the most, or what the colon cancer, which stage was the most?
Yes.
Okay,
What is the most seen stage at initial diagnosis?
I will get the official statistics in a second for you.
And while she's looking, I'll quickly answer this one question that I just saw from Lisa about anxiety. And I just was talking to Milena about this yesterday. I had to go in the hospital for a screening, and my anxiety was very high. As a survivor, I also have asthma. I also am staying with my parents who are, very immunocompromised for various reasons. And so my anxiety was really high to go into the hospital, but I felt most safe there once I got there, had my mask on, everything was labeled social distance, even in the waiting rooms, you were social distance between people. I think the safest place is probably the hospital at this point. They're testing, most hospitals, like Milena said, are testing you for COVID ahead of time. So they're not gonna let anyone in for a procedure or any reason if they're COVID positive. They're asking screening questions. And then again, everyone there feels the same anxiety that you do. Once I got there, I felt much safer. I think the anxiety to go in, yeah, it's going to be there. Of course, I have anxiety going to the grocery store, which I don't even do. I have my groceries delivered. But knowing that you're not alone and everyone at that hospital or that has to have a screening test feels the same way you do, I just told myself to breathe in and breathe out and know that I was wearing a mask and they're wearing a mask. And that's the safest place, like I said, the safest place you can be is the hospital right now.
So stage 1 is the most common, and then stage 2 and 3 are follow about the same, but much less. And then stage 4 is the least common. I will say in our younger patients, we're typically catching them at later stages with more aggressive disease.
Thank you. So that's why it's very important to do the screening, because you catch it at an early stage, right?
Right.
The majority of them.
Yeah, and for our younger patients, if they have any concerning features like change in their bowel habits or blood in their stool, to get evaluated early and not wait till the screening age.
Perfect. I have another question. My dad refuses to get a colonoscopy. Do you have any tips for convincing a stubborn parent to get one? Saying you could get cancer and die has not been a successful strategy. Can anybody enlighten us with some tips of how to convince somebody that doesn't want to get screened?
I mean, I think I'll speak quickly because I'll let everyone else give some tips, but from a survivor, I know if they have the opportunity to talk to someone who has gone through the screening or has gone through cancer treatment or has gone through the prep, it really is that conversation one-on-one helps a lot of people. I know I get people asking me when I'm out in the, teaching providers or staff in the community about, the prep is the worst thing. Going in for the colonoscopy is the worst thing. What I say is that colonoscopy and screening is much better than cancer, number one. And number two is once you have that colonoscopy, if that's what you're having, and it's clean, you don't have to have it for 10 more years. So 1 day, 2 days, including the fluid, the liquid diet and clear liquids, is worth going through cancer treatment. So I think the more stories and more testimonials they can hear from maybe friends or family, because it's 1 in 24 are diagnosed with colorectal cancer. So the likelihood of you knowing someone that's diagnosed or has gone through it is very, very high.
And to chime
I would add,
oh, go ahead, Erin.
sorry, I was going to add, if a colonoscopy is a no-go, because there are people that just refuse to do that. The messaging and the options that there are screening tests available that Dr. Gould-Suarez talked about in her presentation, either a FIT or a FIT DNA Cologuard, that they can do in the privacy of their own home. It's not something that they have to do in a doctor's office. Can be done on their own time. And if cost is an option, those are really good options. If they're worried about a colonoscopy, copay, or something like that, that the FIT and the Cologuard are really good options if the colonoscopy just isn't. The caveat being, if the FIT or the colonoscopy comes back positive, then, or the FIT or the Cologuard comes back positive, a colonoscopy is then needed to just confirm that result. But the message of options for screening, I think, has really resonated with a lot of people.
And to chime in on what you guys are saying, and Allison has done this inside Harris Health, is actually a strong provider recommendation. If you trust your provider, if in this particular case, with the hesitant senior that may not want to have their screening colonoscopy, you know, and same thing with Eddie T and Archie, having an annual FIT, if that's the test that you choose to have, make sure you have it every year so that there can be something that the provider can reference to. And if there are any changes, then maybe the colonoscopy will be necessary. But in the event that a colonoscopy is necessary, having that solid relationship with the provider, having the provider to have a strong recommendation and being able to relate to the patient, and in addition to talking to other individuals that may have had a colonoscopy in the past, that can really share their firsthand experience, not just telling you this is something you have to do, versus, you know, someone who's been through it, knows how it feels, knows getting over the ick factor and going to have it done. I think those would be some great choices or great recommendations for someone who might be a little hesitant.
All right.
See a couple.
We're getting.
Oh,
go ahead.
I just see two other questions I would like to quickly answer before we wrap up. One is, does the number of polyps determine the frequency of screening? And yes, it does. So having polyps will decrease your frequency often. So if you have a normal colonoscopy and no family history, you would get a colonoscopy every 10 years. But if you have polyps, that will decrease the amount of time in between. So depending on how many polyps and what their pathology is, it can be as soon as a year to 3 years to 5 years. So that is very important. That's a great point. And someone else asked, what age do you not have to have a colonoscopy? So typically we stop screening at age 75, or when you have what we think is less than 10-year life survival, then the risks outweigh the benefits. So I just wanted to quickly get those out there. And I'll also make a point, if people have questions that were not answered, we will discuss this at the end, but we'll be happy to answer them offline later.
Okay. It looks like we are 1 minute in. Betsy, are there any quick questions that we can do before I have closing remarks?
Yes, I just want to mention that we have this, the theater outreach program is in Spanish. We have resources in Spanish.
I think she froze, but I'll reiterate what Betsy was trying to say. Our theater outreach program not only focuses on colorectal cancer, but it focuses on cervical, breast, and HPV vaccine. We have these in English and Spanish. We also have this available if you have access to Viet TV. We show our colorectal and cervical once a month on Viet TV for the Vietnamese speaking population. So to wrap things up, on behalf of the Daniel Duncan Comprehensive Cancer Center, Office of Outreach and Health Disparities, Baylor College of Medicine, and the Colon Cancer Coalition, I would like to say thank you to our panelists, our media guru, Rob Dickahu, and to everyone attending this webinar and participating. If anyone would like to contact us about collaboration opportunities or how we can bring this or any of our monologues to your communities, feel free to reach us by Facebook, Twitter, or by email. This presentation will be emailed to you in a few days. And if we didn't get a chance to answer some of the questions, like Dr. Gould said, we will reply by email to the questions submitted in the chat or the Q&A. As a reminder, we really would appreciate if you all would complete the evaluation by clicking on the link that will pop up in the chat, or by using the QR code. Dr. Gould, if you don't mind sharing your screen again. It is also included, like I said, the QR code is there along with the link to the SurveyMonkey. This concludes our presentation. Stay safe and make sure to spread the word on cancer prevention during COVID-19. Thank you and have a great day.